We now proceed to the Symposium 4, dedicated to South Asian Clinical Toxicology Research Collaboration, highlighting pesticide regulations, snake envenoming, and suicide prevention. It is my pleasure to invite our chairpersons, Professor Indika Gawarammana and Professor Shaluka Jayamanne. I now warmly invite our chairpersons to introduce the speakers and panelists for the session. Over to you, sir.
Thank you and good afternoon, everyone. Thank you for staying back. This is symposium is about summarizing what we've achieved over the last 21 years. We've South Asian Clinical Toxicology Research Collaboration is into its 21st year. And we've done quite a lot of work and making serious impact in the outcome of patients who self-poison themselves. And this all started in 2003. They came, they conquered, but have never left. They're still here. And today the panel will represent 3 generations, actually. Nick and Andrew, who supervised me, along with Michael. And then there's Anjana, who was my second MPhiS student. So it's like 3 generations. And the first speaker is Professor Andrew Dawson. We were told that a CV would yes. So he's a young professor at La Trobe University School of Psychology and Public Health. He's also director of clinical pharmacology and toxicology at the Royal Prince Alfred Hospital in Sydney, and the director of the Australian National Poisons Centre, Poisons Register. And over to you.
Okay, thank you very much. I'd like to thank the college for inviting us to speak today. And I'm going to speak to you about an unrealized potential that is of collaborations. And to my mind, I'm going to at least express a view that I think Sri Lanka has flown very much under the radar and is underappreciated as a potential collaborator in international research. And I'm going to suggest in this talk that a properly constructed relationship can be productive for both parties in collaborative research. I'll acknowledge the irony that I'm standing up here as a foreigner talking about collaborative research, but nevertheless, I'm going to press on. So 46 years ago, I came to Sri Lanka. I did an attachment with Professor Dhammadasa, and this is a quote from him that profoundly influenced my professional career, but indeed that period of time in Sri Lanka really has influenced my life. Then subsequently, 21 years ago, I moved to Sri Lanka as part of this research project. And I'm going to go through and outline some of the factors around South-North collaborations or partnerships, what they are, why they are, where SACTRC fits in this, talk a little bit about value and benefit, and then highlight some of the challenges in establishing these relationships and continuing them, in particular to get the most value out of them. So the ideal relationship should be one that approaches a clinical problem. And here we have the parable of the elephant being examined by multiple blind men, each of whom has a distinct impression of what that animal looks like from their limited view. If you can figure out a way for the blind men to communicate, you might get a picture of an entire elephant. And to some extent, this is what we try to establish when we set up research collaborations. So in a north-south or south-north collaboration, you're typically linking a high-income country with a lower middle-income country. You're hoping, ideally, for an equitable relationship where you bring together complementary strengths, you have some shared and agreed goals, a reasonable distribution of benefit, however you measure that, and And in an ideal circumstance, possibly an institutional partner who would give you some sustained funding so you wouldn't have financial anxiety. So that's the ideal. The reality, of course, is not that. The collaborations are complicated. This is an analysis from Nature, mostly looking at natural science, but looking through journals over about 15 years, and they found that only about 2.7% of publications came out of these kind of collaborative relationships. And even in those publications, when they looked at them, there was a disproportionate weighting of authorship for the higher income countries taking at least first authorship or primary authorship. So what they were highlighting there, at least in this field, that inequity still exists, and this can be a real issue in establishing, in particular, a sustainable relationship. Now, obviously, all relationships can differ and how they're constructed can differ, and I'm going to suggest to you that it's really important how we look at this if we realise this opportunity for Sri Lanka. But here is another reality. This is a map of the world drawn back in about 2003, distorted by the actual amount of suicide. So you will see here that the global burden of suicide exists in lower middle income countries, and it does so primarily because of pesticides. And so that's a global reality. And around the same time, one of the things that was really pivotal in Sri Lanka was the acknowledgement of the really high rates of deaths from suicide. And Sri Lanka was able to acknowledge that because it actually has good public health and the honesty to count events. So many countries don't do that. And because they acknowledged that problem and because that became a policy issue, this was a reality for Sri Lanka. So in 2003, an opportunity arose to develop another North-South collaboration. And that opportunity was the Wellcome Trust had negotiated with the Australian National Health and Medical Research Council, really in a way to try and get Australia more involved in global health, for a partnership grant. And that partnership grant was one to build collaborative and capacity building. At the time, at the time I was in Anuradhapura speaking with Michael Eddleston, and Michael had been working already with the Oxford Colombo collaborative group, and what we realised that there was some real strength in Sri Lanka, and these strengths in Sri Lanka exist not just in toxicology, but really I think throughout the health sector. So we certainly had a track record in collaboration, but Sri Lanka's strengths are, a strong public health system, really good policy recognition often of really, of good health issues, so you don't have to debate that. A skilled workforce, which is highly trained in, certainly for an Australian, in a way that we recognise and very similar to our training. And then the geographic advantage that Sri Lanka has of being an island. So in many ways, that produces a sense of control of circumstances that if you can't demonstrate things in Sri Lanka, much more difficult in more chaotic areas of the world where there's cross borders. What we had in Australia, in this Australian part of the collaboration, was we had some track record of collaboration because we'd started to work in Sri Lanka. We had access to grants, and this is often what a higher income country, brings to the table. We had clinical toxicologists, actually pretty good clinical toxicologists who were leading the world in research at that time, in particular in toxicoepidemiology. And then one of the things we had is we had the capacity to have some people who are willing to fully commit to research to get this project off the ground, something that's always been challenging in Sri Lanka for someone to be a primary researcher as well as feed the family. So we were successful in getting that grant, and this is what led to the formation of SACTRC, the South Asian Clinical Toxicology Research Collaboration, a title, but also a branding exercise to try and give an identity globally so that people will acknowledge things. And I want to, utilise this as a case study a little bit to look about what worked and what didn't work, and what I think is still a viable pathway forward for Sri Lanka. So it was funded by Wellcome Trust and the Australian NHMRC. And our stated aims we were going to build capacity, and because we're Australians, we just said, look, we'll just halve the death rate. We thought, why not have a big picture? We're going to establish a regional toxicology centre, and at the time we said we'll train in that 5-year grant 3 postgraduate students. We thought we could achieve that. So our methodology is we look to find regional and provincial collaborators, and in these circles around Sri Lanka, these are all hospitals where we set up clinical units. And to set up a clinical unit, we had to have engagement with local clinicians and physicians. Then we got 6 to 8 clinical research assistants, and we put them into the hospital to work in collaboration with those clinicians. But to collect data, we'd have to get someone in to coordinate them. We'd have to house them. We had to get a cook. Subsequently, there were many marriages that I had to attend. So this occurred throughout the island, and then we largely conducted observational cohorts. That is, we collected all the patients, made careful observations, and within that we nested clinical trials in hospitals. That's where we started. So how did things evolve? Well, in terms of the actual collaboration, what SACTRC had is it increased capacity. So we had postgraduate students. I'll come back to that later on. We had research staff. So we had all of these, mostly pre-interns, and at various stages, up to 120 employed at any one time. And then, very importantly, we developed a research support infrastructure. And this was a back-end office that was able to manage logistics, employ people, coordinate things, tell me I'm about to do something stupid. So that was very, very important. Then we had, in local partners, SACTRC did not set up specifically in a university, although we had office space in Peridiniya. But our local partners included the named investigators in Sri Lanka from the grant, who was Professor Rezvi Sherif, Professor Nimal Sananaika, and Ravindra Fernando, because we were only allowed to have 3. But we very rapidly went out to most universities looking for postgraduate students, saying that those postgraduate students were still a student of the university, but we were going to help resource them. We also partnered up with provincial health, national health, as well as some regulatory authorities in Sri Lanka. So very interesting, once we built that capacity, once other people started noticing this in the world, we started to get other partners, notably from Denmark, also Switzerland, Germany, some in India and Bangladesh. So in a sense, if you build an infrastructure that looks stable and things, people would suddenly think, actually, I think I can work with that and I don't have to duplicate the infrastructure. And that led us to expand our research. So we were interested, obviously, in poisoning from pesticides. That was our stated aim, but we rapidly went into pharmaceuticals, plants, then envenomation, and some of this data will be presented later on. We became interested in other drivers of self-harm and suicide, so community alcohol use. We were involved in medical education in primary rural hospitals, as well as postgraduate courses, and then more recently in setting up clinical pharmacy and looking at research in that area. So there were challenges, however. So if you decide to have a big group all spread around doing multiple things, communication between that group is actually quite complicated. For an individual clinician in an individual hospital looking at that project in front of them, they might understand that, but not necessarily get the whole context about where you're going as a research group or what your strategy is. So this is a continuing issue, and certainly, as you're all aware, in Sri Lanka, periodically you can have misinformation in newspapers. There can be a lot of things that you need to manage. So maintaining communication is very, very important, and local engagement's really important in doing that. Then there's really the challenge of sustainability. When you have all these people employed, you're somewhat responsible. And one of the problems you have in these grants is that, or in sustainability, is you've got to get money. And most of this money comes internationally. It's intermittent. It's highly focused on whatever people think is important. And so there may be a mismatch between that global agenda and what your local needs are. And you need to figure out how you navigate that and be clever in order to respond to locally led demands. And there can be a misunderstanding about collaborative research. We've literally applied for grants to do research in Asia, which were the call to find reviewers saying, I don't understand, all the research appears to be done in Sri Lanka, not Australia. What is this about? So people don't necessarily understand things. Then there can be shifting financial and political environments. Funding bodies may suddenly decide they don't want to have a global health program anymore. So suddenly your money can change or your access. So you need to figure out the money, but you still need to have a stable research structure, because to get money, people want to see a structure they can deliver money to. And then the other thing is to transition to local leadership. If you have a capacity building program, clearly if you can't find good people, then you're failing. So where were we at 21 years? We had continuous grant funding from multiple sources. I'm going to come to the postgraduates. We've got a research infrastructure. There's a lot of publications, and there's been policy translation, which the subsequent speakers are going to talk about. So I want to just highlight here, this is the pivotal role of postgraduates. Whilst we said we're going to have 3, we ended up to date with over 40 postgraduates, 30 of which have come from Sri Lanka. And it's these postgraduates who largely drove the fidelity and quality of the research in the field. So they're absolutely critical. They helped contribute to the large number of publications, and the group has got a very big number of publications over the years. But what I think is really important, I want to highlight this slide, is the number of first author publications that came out of Sri Lankan research. So if you look down here on the left, very few of our first author publications the first couple of years came from Sri Lankan researchers. But by 2007, our postgraduates were starting to produce and to finish, and really have been a predominant driver of first author publications. In fact, interestingly, because they took a while to publish, but they were presenting stuff such that in 2005 in the European Toxicology meeting, more than 50% of the oral presentations came out of Sri Lanka. So Sri Lanka, in the weird, small specialty of toxicology, rapidly became quite a driving and dominant force, and well recognised for the quality of its research and the opportunity in Sri Lanka. We're not immune to the idea of examination and research, and in 2006, Sala Sariola, a medical anthropologist, came and spent 2 or 3 years studying us, speaking, both SACTRC and another research group in Sri Lanka, talking to people throughout the organisation to understand and hopefully explain to me what I was doing. And we're almost finished here. So, but what she determined, from our from those things, is that local Sri Lankan researchers and clinicians were critical and creative agents who really shaped the collaboration. So by and large, we came in, we were trying to respond to questions that we had found or clinicians told us were important, and then act on those and figure out a way to fund it. The research process is really a process of development, not just coming in and flying out, but it's about developing infrastructure and people to move on independently. And importantly, that ethics are complicated and often negotiated and not universal. And this is one of the other final challenges for us, that we often dealt with multiple local and international ethics committees that often had quite different concerns, often clashing concerns. What did not concern people locally, international people couldn't understand. So this is one of the things that needs to be resolved. Sri Lanka is actually doing a lot of current work in this space about developing ethics capacity in Sri Lanka and looking at that, in particular the Institute of Research and Development, but other bodies here. So this is a really important area in doing research and making certain that we're getting good value. So there are many metrics to examine things, but I think that it's not just about publications, although we've achieved that, but capacity building and a big postgraduate program, I think, for anyone in Sri Lanka looking for these collaborations, should really be looking to get that investment from their partners. And then finally, the other speakers will talk about translating our research into practice and policy is really, really important. So at the end, I think there's really impactful results that can come from enduring partnerships. And these are both locally, but also I think globally. And I think Sri Lankans underestimate their potential influence globally and their ability to change things. My other speakers will talk about that. Sri Lanka has got attributes of being a strong partner in most fields of medicine. So I think it needs better marketing and better partners. That capacity was a key driver for SACTRC's success. And I want to acknowledge the high level of trust from all the SACTRC collaborators, of whom there have been many, many, and the research team that literally now after 20 years have kind of gone into 500 or 600 people. So thank you very much.
Sorry. Our next speaker is Professor Michael Eddleston. He's no stranger to Sri Lankans, and he is the professor in clinical toxicology at the University of Edinburgh and honorary consultant physician at Royal Infirmary, Edinburgh. He came to Sri Lanka as a medical student and had a very long career in research in Sri Lanka. And I won't take much time, and it's over to you, Michael, to speak on lessons the world has learned from pesticide regulations in Sri Lanka.
Hi, thank you very much for inviting me to give this talk to the CCP. It was a long time ago I came to my first one with Resvi Sheriff, who was my long-term mentor and supporter. I've changed the title slightly, but it says the same thing. So what has the world learned from Sri Lanka regarding pesticide regulation and pesticide poisoning? I don't have any conflicts of interest. So pesticides came to Sri Lanka in the 1960s as part of the Green Revolution. This is a way of changing agriculture. It had new strains of plant were more efficient, it had fertilizers, and it had pesticides. Probably pesticides were the least useful, though the story, that isn't the case, but they're probably not that effective. As a result of those three things, we had increased food production. Here's wheat, for example, globally in India, and also a reduction in malaria. It was almost eliminated in the 1960s. But if you start using highly hazardous pesticides, there are problems. I'm sure everyone in this room who's a clinician has seen patients like this coming into hospital unconscious after ingesting a pesticide. So what's the scale? There's been at least 14 million premature, unnecessary deaths since the Green Revolution across the world. There's 150,000 deaths every year because of these pesticides in people's communities. And for every death, there's probably around 20 poisonings. They mostly occur in low and middle income countries where people have easy access to lethal pesticides because everyone's a farmer in many areas. If we look in Anuradhapura district, 80% of households store pesticides in their house. And these are not a safe, dilute ones. These are highly concentrated agricultural pesticides. So what did Sri Lanka do? The problem was first reported by a Sri Lankan physician, a man called Vetanayagam, who was a consultant physician in Jaffna Hospital. He wrote in 1962 in the Ceylon Medical Journal and the British Medical Journal to say, this is a problem. People are dying all across the world from this, and I'm seeing that in my hospital. And he writes very clearly here, in my opinion, Folidol or parathion should be classed as a poison and controlled accordingly. It is too dangerous for use in the hands of the average Ceylon farmer. He was absolutely clear. Sri Lankan farmers should not have access to parathion. Then in the 1980s, another Sri Lankan clinician took over, Jayamanne, and he started pointing out this is a global problem. He looked occupationally in Sri Lanka and showed the deaths. And then he moved across 4 South Asian countries and showed this was a problem there too. His work led to this 1990 document on the right, the public health impact of pesticides used in agriculture, the first dawning realization in the global public health groups that this was a problem. So how can we address it? We can address it at 3 crude levels. We can treat patients better. We can control how people use pesticides. How are they used in communities? How are they accessible? Or we work with governments on pesticide regulation. Now, Nick's going to talk about better treatment. I'm going to talk now about pesticide regulation, but with a small amount about community. Now, if we look at the hierarchy of controls, which came in the 1950s, and say, in terms of public health, what works? What really works is elimination? Look at this and think about car crashes. What would stop deaths from car crashes? Obviously, get rid of cars. Or you substitute, make cars smaller. Or make people drive slowly. But has anybody here not broken the law while driving? We all drive a little bit too fast. So those rules are not very absolute. And PPE is effective as a treatment. People have done it, they come to the hospital, is it going to work? So that's the least effective, but Nick's going to talk about that. It shows it's actually quite effective. So we're going to go now to control community use. This is really important. In 2005, The global discussion was safe storage was going to solve pesticide poisoning. If you put your pesticides away every night in a box, no one would die. Well, that's kind of true, but it's very difficult to do. And I have inscribed on my memory a photograph of a girl, 12 years old, in Anuradhapura district, whose mother's in the Middle East, her father's an alcoholic, and every day she has to lock the pesticides away and hide that key. Now, if she doesn't hide the key successfully, and her father finds it while drunk, drinks the pesticide and dies, who's going to be held responsible for his death for the rest of her life? That's what public health was telling people to do. Families take responsibility, and if you make a mistake, it's your fault. And that wasn't just industry, that was the whole discussion at the time. So Flemming Conradsen, this wonderful Danish guy, set up a study in collaboration with colleagues here to find what might work in terms of storage and designed this container. With Shaluka Jayamanne, who led the study here in Sri Lanka, and a group of methodologists and A-level students, or post-A-level students, we set up the study of 180 villages. The people who got the box, received the box at a church or a temple or a school, buried it in the ground, filled it full of pesticides. If it's going to work, this works. The only thing that destroys this is an elephant. If an elephant stands on your thing, you lose your container. But other than that, it's pretty good. We randomized 223,000 people in 53,000 households. And you can see the blue households got the box, the red ones didn't. And then, if I give you all a toy, when will you use it? The first few weeks or after 2 years? I argue, I get a toy, I use it in the first few weeks, then I maybe get bored. So if I give you a safe storage box, when you're going to use it, it's going to be at the beginning. So let's see when it worked. In the first 52 weeks, this was in a person's house, it made 0 difference on reducing pesticide self-poisoning. This doesn't work. But we can do something else here, and this is where Manja did some really nice work. Around 20 to 30% of people go to a shop to buy the pesticide before drinking it. So perhaps we can work with pesticide vendors to help them not sell it to someone who's going to drink it. So we've just finished a study. It was huge. We've got a population of 2.5 million, 6 districts of northern and central Sri Lanka, 750 pesticide shops, 1,500 vendors trained not to sell pesticides to someone who they judge is likely to drink it. It's called gatekeeping. It's really hopeful to be useful. We haven't published the results, but I can tell you the results are very disappointing. This doesn't work either. So we have 2 interventions that are supposed to work at the community level. They don't. So here's the Sri Lankan suicide rate. One of the few things the British could do is do good data. They're useless in many other things. They ruin the country. Other than that, they got good data. So 1880 onwards to 1960, a reasonably low suicide rate. Something happened in 1960, and that was not the British leaving, that was the Green Revolution. So the Green Revolution put pesticides into everyone's house, and suddenly self-harm was no longer safe. And self-harm is about communication, communicating my anger, my distress. I don't think I can tell you how much pain I'm in unless I hurt myself. Then you'll understand. Here we have the suicide rate going up. And what works is pesticide regulation. So these 2 remarkable people, Dr. De Alois and Dr. Maruira, recognized there was a problem and started working out what they could do about it. Initially in 1984, they banned the 2 major problems, parathion and methylparathion, and that huge increase stopped. Then in 1995, they banned all other highly toxic pesticides. And then they found other problems come up, they banned those too. And what you can see is one of the biggest falls in suicide ever in the world. And this is from all means, not just pesticide poisoning. And this was a result of pesticide regulation. The rates of self-harm and self-poisoning stayed the same. They didn't fall, they even went up. But self-harm became safer. Not safe, but still safer. So was this recognized globally? Yes. Sri Lanka won a global policy award. It's like the Oscars of policies. Sri Lanka won it for its combination suicide prevention and pesticide regulation. And what I like doing is meeting people now who are not dead because they didn't have access to Folidol. They had much less toxic, more modern pesticides. So these 3 people all drank pesticides at moment of crisis. All 3 of them survived because the pesticides they now ingested were much less toxic. Of course, agriculture is going to be ruined by the lack of pesticides. It's obvious. But if you look in 1995 on these graphs and compare Sri Lanka in red squares to the other South Asian countries, there is no effect at all from 1995 onwards when those pesticides were banned. And what this says is intelligent, careful pesticide regulation can completely protect people without affecting agriculture. So what we're trying to do now, there's a big challenge to try and get down to the level we were in the 1940s. And there's a single compound now called carbosulfan. It's responsible for 60% of all deaths in Sri Lanka from pesticide poisoning. There is huge drive now to remove that from agriculture. Every time one of these highly toxic compounds are removed, they're replaced by less toxic compounds or to more agroecological approaches. So that's what's going on now. This is what works. We can debate a little bit later. We're all doctors. We want to give better medical management. We can do that. But what really works ultimately from any public health perspective is regulation. So why does it work? Well, means matter. If you have access to lethal means, like a toxic pesticide or a gun, self-harm becomes lethal. So if you can get rid of that, the rates of death will go down. Possibly not, well, the rates of self-harm won't, but people stop dying. And I think that's deeply important. Many of these people don't want to die. They're not drinking pesticides to die. They're drinking pesticides to express their distress, their anger, their fear. Most people do it very spontaneously. Maybe just after a few minutes, they grab whatever's close. They're not choosing the dangerous bottles. And most don't reattempt. So has anyone followed this outside Sri Lanka? Here's a newspaper article from the Guyana Times in 2017, and the title is Suicide Prevention, Strategies That Work. A big article about the problem in Guyana. The last paragraph talks about this. The government needs to intensify its efforts and follow the Sri Lankan hazard reduction model, which is by far the most successful pesticide suicide reduction plan ever. So let's recognize what happened here. We know it's not just in Sri Lanka. Other countries have followed suit. So if you look at all these graphs, you can see that the red line, there's a line down the middle. That's the timing of pesticide regulation. And after the regulation, there's a reduction of pesticide suicide rate in red, and often in the overall one as well in blue. And here we can see in India, Kerala, China, Bangladesh, Korea. There are multiple countries where this has worked, Japan as well. And this work was done by Bruno Rubo. The really exciting thing now is India has now finally followed. India has been watching what Sri Lanka has been doing for more than 15 years. I know of government discussions going on in India, and in 2018, they finally banned Forate. Forate is as toxic as sarin nerve agent. Can you imagine going around and saying, please use this in your agriculture? It's like sarin nerve agent, but try to be careful with it. Don't drop it. They've also just banned, so this Gazette of India is in 2023, they finally banned monocrotophos. Sri Lanka did it in 1995, India did it 2023. So don't let anybody tell you India's ahead of Sri Lanka. They've also just banned paraquat on the right-hand one in 2023, and Sri Lanka did that in 2008. So people do catch up with you ultimately. The World Health Organization has completely shifted its priorities, how it tells people to do things. This document on the left-hand side was the first document to say, pesticide regulators must think about suicide. This is not something outside of their ken as it's been previously done. And that was an FAO and WHO document. The one on the right-hand side is an analysis of cost-effective approaches to mental health. And they worked out that pesticide regulation was the most cost-effective intervention possible. And that became a World Health Assembly resolution that everybody should be doing that. There's a suicide guide, came out a couple of years ago. A whole section of it is about pesticide regulation with Sri Lanka as the model. A more recent document from the United Nations Environment Programme, again, is part written by a Sri Lankan and uses the Sri Lankan data. So the data from here is everywhere. It's driving public policy throughout the world. So the WHO ambition is to reduce pesticide suicides by 90%. It's effectively the low-hanging fruit of suicide prevention, because we know the majority of people then don't go on and die from other means. So what we're trying to do, or what they're trying to do, is to make pesticide suicides a thing of the past. And if we can reduce by 90%, which is absolutely doable, we'll reduce global suicide by 15 to 20% and be 2/3 of the way towards the SDG target 3.4.2. And there's no other way people can see of getting there. So the final slide to summarize briefly, what has the world learned from Sri Lanka? Well, first of all, they learned it was a local problem, and that was Vetanayagam. Then pesticide problem was a major problem. Jayamanne took that on, and over 10 years, he transformed the global picture. We know that focus bans are highly effective at saving lives, and that's to Alvis and Manawira. And if done carefully, they don't affect agricultural output. And Nick and Gawarammana Manawira did the paper to show that for the first time. We've shown that improved household storage simply doesn't work. This is not the right way to go. And again, you're going to blame that person in the household if people die, if that key is not hidden perfectly every night. Pesticide regulation is the most cost-effective mental health intervention. It's obvious, WHO. And the most recent document that pesticide regulation should be a part of every country's suicide prevention strategy where pesticide poisoning occurs. And again, India has just added that 2 years ago to their national policy. And this has been called the Sri Lankan method for suicide prevention. And I can't think of anything that stands out better for Sri Lanka than have something named after itself as being the most effective way in the world to stop people dying. Thank you very much.
Thanks, Michael. Thank you very much. Our next speaker is Professor Dick Buckley. He's a professor of clinical pharmacology at the University of Sydney, also a clinical toxicologist at the New South Wales Poison Centre. And he's also the chair of the editorial advisory board of the Australian Medicine textbook. Over to you, Nick.
Thank you. And thanks again to the Ceylon College of Physicians for inviting us to speak. My topic is really about what have you people done to reduce the case fatality? And not as much as Gawarammana Manawira, but quite a bit. So I will show you this paper, and I'm hoping that this will work. Does that work on there? No, I've got to go over here. So we were here when SACTRC was working when paraquat, fenthion and dimethylate were banned. And in fact, we provided the data that helped justify those bans. And you can see that they accounted for, between about 10 and 15%, 15 and 20% of, but I don't have that controller. Where is that controller? Oh, there it is. I can do this on the screen. Here we go. I think. It's not moving. Oh, okay. Sorry. So yes, you can see this blue is the proportion of the pesticide poisonings that were the 3 pesticides that were banned. And here's the influence of the bans. So the bans came in over this time, phased in, and you can see those pesticides were largely removed. You get the occasional pesticide that's banned, still causing a poisoning, because it's sitting around in someone's house for years. But essentially we stopped that. And you can see here the case fatality, that is the percentage of people dying every time they come into hospital, went from around 15% when we first started the cohort down to around 5% or less after the bans. But here's the interesting thing. It wasn't all the bans. And so that's what my talk's about. So here's the case fatality, this lower line of the non-banned pesticides. So we actually had a drop in mortality for non-banned pesticides over this time. And so why did that occur is the question I'm prompting. And when you look at individual agents, and this is almost designed not to be able to tell what their agents are, but the red is the earliest cohort, and then the purple's the middle 6 years, and then the blue's the last years. And you can see in most cases, it dropped over time. And so I'll zero in on a particular group. And so here's our organophosphates. And you can see that weren't banned. And you can see that their case fatality was higher in the early years. So this is the case fatality with the confidence interval, and it dropped in the next, and then it dropped. And you can see that all of them reduced over time, in terms of their mortality when they turned up to hospital. So what drove this? I'm not sure I've got the answer, but I'll suggest that there were a few things. And so the first is, in this first period, this is before the bans even occurred, we seem to see a drop in case fatality overall and in the non-banned pesticides. And what happened in that time in the hospitals was pretty simple. So this is the first people that started working for SACTRC in a hospital. This was known as the P team. And all they were doing was doing rounds every day, twice a day, checking up on people, recording observations, and we discouraged the use of lavage unless they had a protected airway, were intubated, for example. And key thing here is we started doing titrated atropine. And so atropine, as you would all know, is our number one antidote for organophosphates. So when you look at what organophosphates do, they inhibit acetylcholinesterase, and then that acetylcholine has some nicotinic effects, but a vast majority of the toxicity is being caused by the muscarinic effects that we can block with atropine. And in particular, filling up your lungs with secretions is blocked by atropine. And then so very early on in this process, we did this systematic review of what should we do? How should we treat organophosphate poisoning? This is slightly embarrassing, but I'm focusing in on things, but after a long time is a Sri Lankan saying, and gee, it was after a long time that you got atropinized with a lot of the regimens that were being promoted. And I highlight three here, poor performers down here. Hypertox, because that was the one Andrew and I wrote, embarrassingly was right down the bottom. The WHO advice was the same as hypertoxes, and Ravindra Fernando's book. And so these regimens being suggested took over an hour to atropinize people, even if they weren't that sick, and often took 3 or 4 hours if they were actually had a big dose and required a lot of atropine. And so we switched to this new method, which hopefully is what you do now. And that was basically that you're doubling every 5 minutes until you appear to achieve control, and you generally can atropinize people within about 20 minutes. And you're simply watching for the signs of atropinization to appear, indicating you've given enough atropine, because you don't know how much organophosphate's there, and therefore you do not know how much atropine you need to give until you start giving it. So it's like any antidote where you're basically titrating to effect. And similarly at that time, we wrote up a protocol, but this was the protocol we started using in the hospital very early on. And we wrote that up, and it's been downloaded over 70,000 times. And it's a very simple thing. It was designed not for high-income countries. It was designed for countries with basically just atropine and simple treatments. Really importantly, and credit to Ravindra Fernando, we had a discussion about this with him, and he updated his guidelines, and so he was no longer in the, took up to 3 hours, he suddenly was in the, providing advice in that management of poisoning book such that people were rapidly atropinized. And he also changed the advice on gastric lavage, which was another one of our concerns, that people were potentially dying from basically drowning after a gastric lavage. So then, during the bans time, everyone was focusing on what the bans were achieving, which was great, but we see a further reduction, which is an interesting thing. So what's driving this further reduction in this group here? The non-banned pesticides, the mortality continues to drop over this period of time. And it wasn't a new treatment. In fact, it might have been getting rid of a treatment. So we did, around the beginning of that time, we published this study on pralidoxime. And so pralidoxime's had a interesting history in Sri Lanka, I suppose. So Janika de Silva highlighted that maybe it didn't work when there was 6 months where pralidoxime simply couldn't be provided. And that was a really important study in getting people to think about how good is pralidoxime if nothing seems, it doesn't matter if we don't have it for 6 months. And so we later organised, and then there were a few other very small trials, and then this was the first large trial of pralidoxime in organophosphate poisoning. And we had a few aims, but one of them was what sort of concentrations do we achieve? And do we achieve the target concentrations? And we show that. But this is interesting. So these are the concentrations with the variation. And you can see, at the end of period of time, we're getting hugely variable concentrations. So where we think we're giving the same dose to everyone, the concentrations people are getting are quite variable. And pralidoxime is eliminated by the kidney. And so those people with poor kidney function were getting a lot of pralidoxime. And those people with super good kidneys were getting maybe not so much pralidoxime. And you didn't really, there was no monitoring. These concentrations were done much later. And pralidoxime itself is quite toxic. What we did also see was you would get reactivation of acetylcholinesterase. So it was doing what we expected it to in that regard. But, and this is the unfortunate truth, our primary outcome was not those minor, those evidence that it was doing what you wanted it to. It was it preventing death? And here's the pralidoxime arm, how many people are dying over time. And you can see that those getting pralidoxime, 20% were dying, and those not getting pralidoxime, around 10% were dying. And that's in the first 7 days when pralidoxime was being given, and you can see it did not improve after that point. We had a longer term follow-up as our final outcome. So then people go, well, maybe it works for some people and not others. And again, this is just showing, this is a forest plot, but you can see that's the overall, and there is no group we could identify that actually also appeared to benefit when most people were not. And we did a systematic review, and again, really highlighting that even when you combine evidence of our large trial with smaller studies, we're just not seeing much evidence. This is versus the placebo. And around this time, the WHO was reviewing pralidoxime to decide whether it would go in the essential medicines list, and basically they contacted Michael, and Michael goes, yeah, no, our trial is not going to give you the evidence. So they were very excited we were doing this trial. They assumed our trial, and I have to say we almost assumed our trial would be a positive trial, and we could not believe how negative the results were for pralidoxime. But pralidoxime was not added to the essential medicines list. It had earlier been in it, and it was not re-added to the essential medicines list, and it remains out of the essential medicines list. And so maybe that's also improved things. So summary around the current acetylcholinesterase poisoning guidelines is really the number one focus should be on supportive care. Gastrointestinal, I haven't finished a sentence there, but gastrointestinal decontamination, we also showed didn't make much difference at that point in terms of charcoal, and lavage should be used very selectively. What we also were highlighting was that this is quite a complex scenario, so I haven't really shown all that research, but some work done by various other people such as Pradeepa and Nimal Senanayaka showed that we were getting very big differences in how often they got intermediate syndrome between agents. And so it was all about highlighting that this was quite a complex syndrome and it varied by different agents. But the key here in terms of improving survival was this atropine, and that the other stuff, which I'm not presenting, but it was careful monitoring for late weakness and respiratory failure. So all of those things might have explained the differences we saw. The second thing I thought might be explaining that middle period where we got improvements was propanil. And so propanil poisoning, as I'm guessing most of you know, because it is not one of the banned pesticides, but it causes methemoglobinemia. And methemoglobinemia is, in essence, like carbon monoxide poisoning. It stops hemoglobin binding to oxygen and also shifts the hemoglobin dissociation curve in the wrong direction, so it holds on to oxygen tighter. And at around maybe 70% methemoglobin, you're probably going to die, even if you're perfectly healthy. And if you've got underlying disease, a lower degree of methemoglobin is quite likely to be fatal. But it is quite hard to just look at the colour and guess how much of a person's hand and guess how high their methemoglobin is. And then there's also the issue of G6PD deficiency, and people are very worried about if they're giving methylene blue, the antidote, to people with G6PD deficiency. Are they potentially making things worse? Is it a contraindication? Should they start doing something else? And so this is an example of a person who came in and their methemoglobin is high, we work out later. They're given methylene blue, they respond, so they're a responder. They seem to get a bit unwell, they get another dose of methylene blue, again they respond. They get another dose of methylene blue and they respond. But the doctor doesn't know they've responded. And they start doing odd things like giving vitamin C or exchange transfusion or some other treatment when in fact they were actually responding to the methylene blue and they needed no other treatment. And so that difficulty in estimating methemoglobin was a key problem. And Shihana, along with her supervisor, Dharmika, and Andrew, they developed this quantitative bedside test. And essentially this was just a colour chart. You just put a bit of blood on a piece of paper, and hopefully you're all familiar with this, but I'm wondering if you are still. But essentially you can then, very low cost way of just going, yeah, that lines up with that, and that person, methemoglobin is that 60% or whatever it is. And they need methylene blue, and then you can repeat it 5 minutes after giving the methylene blue and go, yes, they've responded, that's nice. So, the case fatality is here in blue, and so propanil poisoning was quite high early on, and when we introduced that colour chart, it appeared to drop. We're not getting that many cases, so the line's a bit wobbly, but it dropped right down, and then it's bounced up a bit. And if we look at our case fatality, it was high, it dropped a lot, and then it's bounced back up. And so I'm wondering if people have forgotten this lesson, and are no longer using the colour chart to monitor propanol poisoning. But for whatever reason, we had a success story, and now the mortality from propanol poisoning has risen again. And we've also seen changes over time in the case fatality of some very low toxicity poisonings. Hard to know what that's about, but it's probably just not doing lavage when there's no great problem in the first place. So in summary, I think so we calculated this was maybe about a third of the reduction in case fatality. So about 2/3 was just due to banning 3 pesticides, but about a third might have been due to improved medical management over this time. And it was really better diagnosis and risk assessment, we think, better supportive care, titrated atropine, less lavage, less pralidoxine. And there may have been all sorts of other things which you will know better than me. But for example, emergency departments came in many hospitals during this time. That probably also helped. Now the bad news. We seem to have flatlined. If anything, case fatality of non-banned pesticides is drifting up. And So I'm interested in whether maybe it's something to discuss. Is there room for further improvement in medical management, or have we done all the easy things that we can do there? And we just need more bans, as Michael would put it, that there's no further improvement possible with medical management. Lots of people to acknowledge. And I just started going through that and I go, oh God, I'm going to miss too many people. And so I just thought I'd just reproduce this. That one pralidoxime trial, this was our acknowledgements. So there are so many people we have to acknowledge their influence and help from Sri Lanka, and so and also our funders. So thanks very much.
Thank you, Prof. Buckley. Next, I would like to invite Professor Anjana de Silva. Professor Anjana is a toxicologist and he is at present the chair professor of parasitology at the University of Rajarata. He has BBS and MPhil from University of Peradeniya, and subsequently has obtained his PhD in toxicology from Monash University, Australia. Apart from many of his description, I would like to mention he is presently the course coordinator of clinical toxicology in MSc in Sri Lanka.
Thank you very much, sir, for the very nice introduction. Good afternoon to all of you, and I thank CCP for providing me this opportunity to talk in front of you all. So I have been in association with SACTRC for I think nearly 17 years. First, in 2008, as a fresh medical graduate, I walked into the SACTRC office to see Professor Andrew with Professor Indika. And then after that, I was doing my MPhil supported by SACTRC. And then after that, I met my mentor, Professor Jeffries Bister, through SACTRC. And my PhD project, which was conducted in Monash University, but clinical studies were conducted in Sri Lanka, was supported again by SACTRC's neurotoxicity grant. And then after returning to Sri Lanka, then I started my own venom pharmacology lab in Rajarata. At the same time, from 2012, I have been working on building up the Anuradhapura snakebite cohort, which is still running at the moment, and it's the largest snakebite cohort in the world. So I'm proud to say that I'm here partly because of SACTRC. So my talk is about actually some of the work that we have carried out over the last about 8 years. And of course, mainly not my work, but my PhD students' work. So I had the luxury of having some excellent PhD students. So snake bite is a serious public health concern across the tropics. We all know that. And Asia is one of the highest affected regions, and Sri Lanka is one of the highest affected countries. So it's occupational health hazard associated with farming, and also it's a disease of poverty. So the treatment that we have for snake envenoming is antivenom. So antivenom was first discovered about 130 years back by the gentleman called Albert Calmet, the very person who discovered BCG vaccine. So since then, the production procedures of antivenom has greatly improved, but the principles remains the same. So at the moment, what we use in Sri Lanka as antivenom is Indian polyvalent antivenom, which covers basically 4 medically most important snakes in India: Russell's viper, Sword-scale viper, Indian crate and common cobra, and it's equine Fab 2 antivenom. And one thing that is where it's infamous for is actually serious acute adverse reactions. Just to show you our data from Anuradhapura snakebite cohort, which is not published yet, but now this graph shows batch-wise, chronologically arranged batch-wise data on the occurrence of anaphylaxis and mild to moderate reactions. So anaphylaxis is indicated in red color, and pink color, mild to moderate reactions. And you see, it remains a serious problem. And there's a marked batch-to-batch variation as well when it comes to occurrence of antivenom reactions. And if you see these blue lines, they are actually representing the percentage of patients who received adrenaline pre-medication for each of these batches. And you see, in the later years, despite almost all patients receiving adrenaline pre-medication, still large number of patients ending up with anaphylaxis. So the other story around antivenom, Indian pollen antivenom, is that there was people actually speculating that Indian antivenom is not working for Sri Lankan snakes because of poor efficacy. So the idea was that Indian snakes and Sri Lankan snakes are somewhat different in their venom composition, so that the antivenom doesn't work. But over the last 10 years, most of our work basically included all types of medically most important snakes in Sri Lanka. We use in vitro studies, in vivo studies, as well as in clinical studies. We clearly demonstrated that there's no problem like that. Indian polyvalent antivenom effectively binds with Russell's viper venom, Indian crate, common cobra, so scale viper, and also endemic Sri Lankan crate as well. So the venom, antivenom, properly binds with the venom antigens in vitro as well as in human samples as well. And also, using pharmacological experimentation, we showed that medically important effects like coagulopathy, pre-synaptic neurotoxicity, post-synaptic neurotoxicity, myotoxicity, they all can be neutralized by Indian antivenom. So there's no problem with the efficacy of the antivenom. And then what about effectiveness? So there are not many studies actually looking at effectiveness of antivenom because antivenom has become the standard of practice, so that you can't have untreated groups, patient groups, to prove that it works or not. But then we were quite opportunistic. In Anuradhapura, we had about 5 patients with Russell's viper envenoming who were not treated with antivenom. That's because the patients, their whole blood clotting test was negative falsely, so patients were not given antivenom. And retrospectively, we were collecting serial blood samples, and we were analyzing the blood samples, and then we found that they actually envenomed by Russell's viper, and they were having coagulopathy as well. So their coagulopathy was persisting, while we compared with a group of patients who received antivenom, and they recovered quite quickly within about 2 to 3 days time. So we were convinced that actually Indian antivenom actually can prevent or accelerate the recovery of venom-induced consumption coagulopathy in Russell's viper patients. So now here's this equation. So Indian antivenom is efficacious, and also we think that it can probably be effective for Russell's viper envenoming. But there's one other problem, that once a patient got bitten by a snake, venom antigens gradually absorb into the circulation, and from circulation they move into the target tissues. And then once they go to the target tissues and start their pathophysiological processes, then reversing them is difficult. So now you have a very narrow therapeutic window in the circulation to give antivenom at the appropriate level. Once, if it is too late, then all the toxins are in the target sites and you can't do anything. So therefore, identifying envenoming is very important as early as possible, and giving antivenom as early as possible is important. The other issue is that nowadays patients come to the hospitals very, very early. So we were studying Anuradhapura snakebite cohort data, and even in the most remote areas, time from bite to first hospital admission is median about like 30 to 40 minutes in even the most rural areas. So they come to the hospital quite early. But then from that point onwards, they spend about median 2 to 2.5 hours in the hospital until they receive the first dose of antivenom. Now that is because basically we are waiting to establish the diagnosis of envenoming. So now antivenom should be administered as early as possible and should be given only for those who absolutely require it because of the serious complications, serious adverse reactions, and therefore diagnosis must be made early. So one of the most widely used tests in detecting envenoming in the developing world, at least the coagulopathy, is whole blood clotting test. So there's 20-minute whole blood clotting test. Most of you are familiar with it. It's just you take 1 milliliters of venous blood into a fresh glass tube, clean glass tube, and keep it upright for 20 minutes. And then after 20 minutes, you flip it over and see whether the blood has clotted or not. So depending on that, you decide whether it's coagulopathy or not. But then my PhD student, Supun, she was actually basically doing a scopic review to understand what are the available bedside clotting tests in the world. And then what she found was that actually there's no reason why people do it for 20 minutes. So someone started doing it for 20 minutes and then everyone followed it. So she basically did 15-minute test, 20-minute, 25-minute, 30-minute test, and all sorts of other available tests. And what she found out was that when you compare it with INA as the gold standard tests, all these tests are equally bad. So this table shows when coagulopathy was defined as INA more than 1.5, how the whole blood clotting test, 20-minute test performs. You see the sensitivity is around like 35.8. And if you define coagulopathy by INA more than 3, sensitivity is around like 62.6. That means the test better detects severe coagulopathy. And then if you just isolate only the Russell Swipe patients, again, it's 62.9% sensitivity. And you see the specificity of these tests are actually excellent. When they are positive, that means coagulopathy. The problem is quite a number of them actually became falsely negative. And then when Supun actually analyzed the performance of these tests for patients who presenting early versus presenting late. So for those patients present before 2 hours, the sensitivity is poor, the whole blood clotting test. But for those who present later, sensitivity is better. That essentially means that basically whole blood clotting test wait the physician or let the physician to wait until the coagulopathy becomes severe enough for the test to detect. So because of that, actually, we suggested writing a lead article in Ceylon Medical Journal, suggesting that we should use INA as much. If it is available, we should use INA to diagnose as well as monitor the coagulopathy. And also, without waiting 6 hours, if the INA is not available, repeat the whole blood clotting test in 3 hours. And then there's another observation that clinicians have made across generations is that those patients with envenoming tend to have non-specific features of systemic envenoming, such as abdominal pain, nausea, headache, and vomiting. So this is actually a study done by Prof. Sam Kurapta some time back, and it clearly indicated that abdominal pain is actually quite predictive of Russell Swipe envenoming. And then in Supun's study, actually, we were thinking about how to incorporate these non-specific features of envenoming with the results of whole blood clotting test to improve the performance of the whole blood clotting test. So what we did was, actually, we defined a diagnostic algorithm where when a patient comes, if the patient has, we check for presence of non-specific features of envenoming, such as abdominal pain, vomiting, or headache. And if it is positive, we consider it as a combined test positive. And if it is negative, then we go for whole blood clotting test. If the whole blood clotting test is positive, then we again consider it as a combined test positive. So likewise, we actually test the performance of this combined test in detecting systemic envenoming of Russell Swipe. So what we found was that when combined with abdominal pain and the whole blood clotting test, so that is abdominal pain or whole blood clotting test positivity, the sensitivity of the test actually improves up to 82.4%, retaining a specificity of 98%. And also, if you consider any of the non-specific features like, any non-specific features or whole blood protein test positivity, then the sensitivity improves up to 88.2%, still having a specificity of 90%. So what this means is that we can effectively combine the non-specific features of envenoming to whole blood protein test in improving the performance of whole blood protein test. And then there were some other, of course, we had to look for more biomarkers that can actually predict envenoming quicker. So we were exploring some of the biomarkers, and what we found was that serum phospholipase A2, or secretory phospholipase A2, is a venom protein that's actually present in most of the snake venoms, so that envenoming can be directly detected. So the table actually shows the area under curve of receiver operating characteristics, ROC curves. And what we found was that we were testing phospholipase A2, serum NGAL, and also serum clustering. And we found that serum phospholipase A2 has a much better area under curve for detecting Russell's Viper envenoming. So I think it's a potential tool for developing a rapid diagnostic test in the future, because in Sri Lanka at least, and if you can compare it with the hump nose viper in the same table, it performs better than, much better than hump nose viper, so that it can actually use to separate hump nose viper from the Russell's viper. So finally, the way forward is actually, there are many point of care devices to detect coagulopathy for other purposes. The problem is that most of these tests fail to detect snake envenoming or give weird results because of, in the snake coagulopathy, there are different types of procoagulant toxins involved, and they are present in patients' blood samples, so that they basically mislead these tests. So at the moment, we are doing another MPhil study with one of our students, currently comparing 3 point-of-care devices, point-of-care fibrinogen, INA, as well as activated clotting time devices, to see how effective they are in early detecting Russell's Viper envenoming. So in summary, one of the neglected issues of snake bite management in Sri Lanka is early diagnosis of envenoming. The attention has been long focused on, suggesting that the antivenom is not efficacious. It's not the case. The problem is now patients come early, we need to give antivenom early, we fail to detect it. So whole blood protein test 20-minute one delays the diagnosis of envenoming clearly, because our patients present much earlier. So INA must be used whenever it's available, and also non-specific features can be effectively combined with whole blood protein test to better detect snake envenoming. So as biomarkers, serum phospholipase A2 is a potential biomarker, and also we have to look for the utility of point-of-care tests in quickly detecting snake envenoming in Sri Lanka. So thank you very much. I have many to thank. Professor Jeffrey Bister, my guru, and then Professor Siribadhan, Professor Wayne Hodgson, and my PhD student, Dr. Supunwada Singh, and also Subodha Vaidinath, and all the SACTRC, everyone from SACTRC, and especially I must mention Mr. Umesh Chaturanga's name, our center manager in Anuradhapura, and also we received funding from NHMRC and Rajarat University, and also my collaborators from Monash, and also my collaborators from Department of Medicine, and all the physicians and emergency physicians from Teaching Hospital Anuradhapura, and my department members. So thank you very much.
Thanks, Anjana. Thank you very much. May I invite the speakers, all 4 of them, onto the podium, onto the stage. We can ask some questions. Are there any questions? May I ask one question from both Nick and Andrew? So what was your biggest challenge when you started setting up things here? That's now my first question. Second question is, how helpful was the physicians, the Ceylon College of Ceylonese physicians, in carrying out your research?
Okay. So the biggest challenge in setting up, I think probably our biggest challenge was we had no idea how quickly things would take off. So we put a lot of things in process, and we got postgraduates, and there was quite a lag, and we had 1 or 2 people starting, and that was very reassuring. And then all of a sudden, literally our workload with approvals and things kind of quadrupled, and we had to employ and train a lot more people. So I think that was a huge challenge. In terms of the physicians, the collaborating physicians were actually critically important, because you really needed that seniority in all the peripheral hospitals. The research assistants were junior. They needed to communicate and integrate well with the local team, even though they're not necessarily delivering care. They were taking observations, and the observations of experienced clinicians in identifying what things were problems actually really informed much of our research agenda, I think, for a number of years. About, sure, we would see things, but clinicians who see hundreds or thousands of cases are often picking up and saying, this is a problem for us. So I think the initial problem was we really underestimated how kind of successful it was going to be at the start, at least in terms of doing more research. So we had to build much more quickly, but we got good at that over years.
Well, and also there were some superb PhD students, Indika. But particularly we were so the commitment of some of our early PhD students, and particularly Pradeepa, who headed off, doing all this research that made us all look good, and so it was those junior physicians who were often the physicians out in the periphery, and particularly those who committed to a PhD program, but just also the others were so that it just simply didn't work if they weren't on board.
Let me ask a question from Michael. Now, you showed that Sri Lanka was very successful in getting research into policy, to national policy, compared with other countries. That's my first question, why we were so successful. My second question is, although we managed to get these things into national policy, our research into clinical practice is so slow. For example, the gastric lavage, even I'm not sure whether the proper methods are still practiced. Why there is a lag in the clinical practice here, on your observations?
I'll give the second question to Nick. The first one, I think, in 1982-83, there was a Food and Agriculture Organization meeting trying to design how to have a pesticide regulation policy. Can I continue? So that was set up, and there were Sri Lankans on that committee. And what Sri Lankans did before the official document came out, they came back to Sri Lanka. They wrote the national policy for Sri Lanka before the FAO one came out, because they were on the committee. So Sri Lanka had people who were interested and engaged and really involved in getting it working. So they brought it back to Sri Lanka, and they acted on what was going on in the community. Many other pesticide regulators did not think they had a responsibility to deal with suicide, because that was misuse. That was not on the label, therefore that was not their work. But Sri Lanka took a much more realistic and a much more intelligent approach. And again, it was based on individuals.
Since you're one speaker short, have you another 5 minutes? Any other questions from the audience?
Pesticides. The
That actually started in 1992. So the regulators banned monocrotophos and midimidopos in 92, but it was 25% reduction each year. So by 95, it completely gone. But the engagement of the regulators with the public health community caused the commission to be set up by the president, which was in 95, and then 97 it was the final documents came out. But that combination of pesticide regulation and suicide prevention was what won Sri Lanka the Global Policy Award, to show that it was kind of the Oscars of policy.
I think we need to close the session. Thank you very much. I think there is a certificate.
May I now invite our chairpersons to award the certificates and tokens of appreciation to the speakers.
Professor Andrew Dawson.